This is a lecture by Dr. Thomas Alexander from Kovai Center, Coimbatore, improving STMI outcomes, symptoms to balloon versus door to balloon, challenges in India, an Indian experience by Dr. Thomas Alexander.
Good evening, and thank you for this invitation, Srinivas. What I'll try to do over the next 10 minutes is give you a sense of what we are trying to develop in this country. You just heard the way myocardial infarction treatment has changed over the years, but really in our own country, it is the question of how do we get a patient to a hospital, and once we get them to the hospital, what is the best way of treating these patients? And I think these are the ground realities that we face, and these are the issues that we are trying to tackle in this project that we are developing in the state of Tamil Nadu. I think we all know this, that from symptom recognition to getting the patient to the cath lab or to the hospital where thrombolysis is being done is the major challenge. But the biggest component of delay in this is in symptom recognition and getting the patient to the hospital. So the question always for us, when we look at quality improvement, is how can we improve the door-to-needle or the door-to-balloon times? And is this the only metric that we need to look at? Because that is actually the easiest metric for us to improve. But clearly this is not the only metric that we need to look at, because that is not certainly the most important thing. We realize that STEMI doesn't start at the door, and STEMI doesn't end with treatment with a balloon or with a needle. We also know that this is a very simple, arbitrary way of looking at how well we do or how well we treat our MI patients. The location and size of the MI is more important, and many of our patients are transported to one hospital and then transported to a secondary hospital for treatment, usually with an angioplasty, and therefore the delays are very, very large when you look at it. And I think we also need to understand that when the US talks about door-to-balloon and door-to-needle times, there are a huge number of exclusions. We look at that, but if you look at the period from 1995 to 2003, you can see that only about 30% of patients in the US had a door-to-balloon time of less than 90 minutes. But this is when the ACC and the AHA took it upon themselves to work towards reducing this. And today we know that more than 90% of STEMI patients in the US have door-to-balloon times less than 90 minutes, with 70% less than 75 minutes. And this is a huge progress in the US. Now, what we saw was, if you look at when this campaign really started and look at mortality rates, there was a very significant reduction in mortality rates with reduction in door-to-balloon times. But if you look at the period beyond 2005, you can see that the mortality rates have sort of stabilized, while door-to-balloon times have continued to improve. And we know from the CREATE registry, and I just emphasize, that the median time from onset of symptoms to getting to the hospital was 360 minutes. And if you were to do a door-to-needle or a door-to-balloon time within 90 minutes or within 30 minutes, you're only looking at a very small fraction of this delay. And this is the challenge in this country. And it's towards this that we talked about this in a recent publication of ours, whether it is time for India to look at developing a system of care where you can address all these issues of delays and not merely look at door-to-balloon or door-to-needle time, which is a hospital-based measurement and is easy to do, but ultimately does not reflect totally on the total ischemia time. And it was with this that we looked at two strategies to develop STEMI India, a not-for-profit organization that we set up. Dr. Ajit Malasari and myself is trying to work on developing a system of care. And what we're trying to do is to combine two strategies. Those of primary PCI, if the transportation time to a hospital with cath lab is short, or when the transportation times are long, to try and do the pharmacoinvasive strategy, which we now know is almost as good as primary PCI, where you would quickly thrombolize the patient and then shift the patient within 3 to 24 hours to a hospital for a PCI procedure. And we know that both these strategies in the recent STREAM study from the US and as well as from our own recent data from the STEP-PAMI study, which STEMI India recently did and which is in the process of being published, shows that both these strategies are almost as effective. The project, the Tamil Nadu's pilot project that we are involved with, there are two collaborating agencies. One is STEMI India and its partners, the ICMR, our technology partners, and the Tamil Nadu Health System Project, which is the government of Tamil Nadu Health Department and their collaborators, which is JVK EMRI, and the state government health insurance scheme, which is interlinked with the project that we're doing. And Dr. Ajit Mulasiri and myself, we are the principal investigators. Now, in the model that we have developed what we call a STEMI cluster, where we have a hub and spoke model. The hub being the hospital with a cath lab, which is linked to multiple hospitals in the periphery. Now, what happens is if a patient self-presents or is brought by ambulance to the hub hospital, he gets primary PCI, while if he goes to one of the spoke hospitals, he gets thrombolized and then is shifted to the hub hospital within 3 to 24 hours to complete the pharmacoinvasive process. Now, these linkages are built on electronic data communication, management protocols which are built in, insurance reimbursement, and this is important, is built into the system, that only if you go through this whole protocol will insurance reimbursement work. And we have a dedicated transport system, the GVK EMRI transport system, which is also a partner of this project. In the pilot, we have 4 clusters developed across the state of Tamil Nadu. We're in the pilot project. And what we have done is to include different types of hospitals in these clusters so that when we develop a model, it is robust enough to be transported across geographies. So we have one cluster, which is a Stanley Medical College cluster, a public hospital linked to multiple private and public hospitals. There is CMC Vella, which is a rural tertiary care hospital linked to multiple hospitals. There's a Kovai Medical Center at Coimbatore, which is a multi-specialty hospital, urban-based, but linked to multiple government and private hospitals, and Madras Medical Mission in Chennai, which is a metro-based hospital with linkages. We have 3 important partners to this whole project. One is our technology development partners, and we have developed this device, which you can just see here, which is a mobile device, which doubles up as an ECG recording device. During transportation, a click of a button converts it into a monitoring device, so you can have ambulatory blood pressure monitoring, heart rate monitoring, rhythm monitored, and these use GPS and 3G to transmit this data to the hospital that the ambulance is moving to. So even before the patient arrives in the hospital, you already have data as to what is happening with this patient. And this is also a data entry device. We are also partnering GVK EMRI, which is absolutely essential when you look at an ambulance system, and with the insurance. This is a below poverty level insurance, which the government of Tamil Nadu covers almost 80% of the population. And for all STEMI patients, whether it's for thrombolysis or for PCI, reimbursement is guaranteed by the government, and therefore no patient who comes into the system will fall through because of financial reasons. I'll just give you a small snapshot in the next maybe 3 or 4 minutes to show you what we've managed to achieve. This is the pre-implementation data which we have of over 500 patients. And you can see that most of the stents that were used in the primary PCI were DES stents. And this is because primary PCI is done mainly in the urban centers. None of the patients, or a very small percentage of patients from the rural outlying hospitals, came to the hub hospital to finish the pharmacoinvasive treatment. So I'll just quickly go through this for lack of time, but clearly what I think the big thing that we saw was, if you looked at the spoke hospitals in the periphery, only about 73% of these patients had no further treatment. That is to say that thrombolysis was the only treatment that was available for them. So we know that thrombolysis is inferior to primary PCI, and you need to go through the pharmacoinvasive strategy. That is, within 3 to 24 hours, these patients need to be transported for a PCI for this to be as good as primary PCI. I'll just show you the first 100 patients that went through this implementation phase. And what we saw immediately was that the stent that was used was more bare metal stents than DS. And this is because most of the poor patients who till then were having only thrombolysis done in the peripheral hospitals were now being transported to the hub hospitals, and using this insurance were getting PCI done. So 52% of these patients were getting stents done, and most of it was bare metal stents. Again, I'll quickly go through this data, but you can see that of the first 100 patients, you can see that 87% of these patients came to the hub hospital. That is to say, either they came directly to the hub hospital, or if they went to the spoke hospital, were then transported to the hub hospital to complete the pharmacoinvasive strategy. And this is a huge improvement as compared to our pre-intervention data. Now, if you were to look at the data, if you look at the thrombolytic subset, you can see that 72% had PCI within 24 hours of thrombolysis. And thrombolysis was mainly done in the spoke hospitals, transported to the hub hospitals, and had PCI completed with them. I'll just show you the comparative data, which will show you what we have managed to achieve. You can see that the type of stent used before we started the project, most of the patients had DAS being used, and this is because it was all the paying patients who were coming to the hub hospital. But once the program kicked off, you had both hub and spoke hospital patients coming into the cath lab, more of BMS being used because that is what is reimbursed by the government. But more importantly, if you look at the patients who were transported from the spoke hospitals or the periphery to the hub hospital, from 6.3%, this has gone up to 72%. If you look at patients who completed the treatment, from just 45%, which were mainly those who came to the hub hospitals in the pre-intervention phase, we've gone up to 87%.
Excuse me, time is up.
And lastly, if you look at the pharmacoinvasive strategy, from 15% to 75%. So clearly showing that we've been able to achieve a huge change in the treatment of STEMI in this country by using this pilot project. Thank you very much for your attention.
Thank you.